I think across this trial, my overall takeaway would be that this is, perhaps not surprisingly from a 1,000-person trial, a pretty representative cohort. So I would say, when we look to take clinical trial results into clinical practice, this cohort to me is pretty representative, and the investigators have done a pretty good job of capturing a valid and actionable high-risk bladder cancer population.
Okay, so Q3 monthly cystoscopies and cytologies as part of, care on a trial, 55%, as you mentioned, T1, 25% had some component of CIS. From the way you've started this whole discussion with us, sounds like pretty standard. And then the pure CIS was about 15%. So we had a median follow-up of about 3 years. Arm A versus C, EFS. Maybe just describe what that endpoint is and then take us through results.
Yeah, so I think it's important, especially for those who are maybe not in the localized space so much, to think about what are important endpoints when we think of localized disease. We think about this in prostate, we think about this in bladder, right? You can't necessarily wait for OS maturation to act on these agents. And so we have to find earlier but relevant disease endpoints. And so when we think about bladder cancer and non-muscle invasive bladder cancer in particular, the two endpoints we're trying to avoid, obviously while keeping patients alive, are disease progression, which would be progression to either metastatic disease, which can happen directly from non-muscle invasive disease, or progression to muscle invasive disease, or high-grade recurrent disease. And so those are really the two endpoints we're looking to avoid with our therapies. And so I think those are really important and valid endpoints to have as the study endpoint here.